Here's the presentation on Chapter 7, Special Techniques in the Thomas and Lerche text. The objectives for Chapter 7 are to define or explain the terms local anesthesia, sensory neuron, motor neuron, infiltration, line block, nerve block, ring block, splash block, epidural anesthesia, cauda equina, tidal volume, respiratory minute volume, atelectasis, controlled ventilation, assisted ventilation, manual ventilation, mechanical ventilation, and sympathetic blockade. And that's why before you started this chapter, you had to go through the nervous system and the respiratory system, and to a degree the circulatory system. B, list the advantages and disadvantages associated with the use of local anesthetic agents. C, describe the ways in which local anesthetic agents may be used, including topical infiltration, regional, intra-articular, epidural, and intravenous administration. D, outline the methods for performing a nerve block and a line block and assist clinical situations in veterinary practice in which these blocks are used. E, describe the technique for performing an epidural block and give examples of clinical situations in which an epidural block could or should be used. F, explain the risks involved and the adverse effects that might be seen with the use of local anesthetic agents. G, explain the difference between assisted and controlled ventilation. H, describe the techniques of manual, mechanical, periodic and intermittent mandatory ventilation and their application to anesthesia. I, list the indications for the use of neuromuscular blocking agents and the hazards associated with their use. J, describe the difference between the two classes of neuromuscular blocking agents, including the mode of action and their reversibility. K, be able to define, describe, or apply the following terms or concepts. And all those terms and concepts are discussed in your book. So be sure you know your terms. We're going to start, basically this chapter is two sections, local anesthesia and neuromuscular blocking agents. By way of introduction, local anesthesia is becoming more popular again. I think all things in veterinary practice go through periods of either popularity or non-popularity, and it's always cyclical. Right now, local anesthesia seems to be making a comeback, and as it should. It's a great technique, has a lot of applicability. There's a lot of good things that can happen with locals. Local anesthesia is the use of a chemical agent on certain sensory neurons to disrupt nerve impulse transmission, leading to temporary loss of sensation. In other words, they can't feel pain. They don't feel it. Indications, if you have a tractable animal, general anesthesia is undesirable or a high risk, or means to deliver general anesthesia are not available. So if you have an animal that's suitable, if they are a high risk or it's undesirable, or even if you don't have the ability to deliver general anesthesia, then local anesthetics are a good option. Advantages, well, there's a lot of advantages to locals. Number one, they have low cardiovascular toxicity, with one exception. They are very inexpensive. They provide excellent pain control immediately post-operatively. In other words, they wake up without any pain. And they have a minimum patient recovery time. We commonly use them in ruminant, obstetric, and abdominal procedures. They are commonly used in complement standing sedation in horses, so we can just sedate a horse and use local. We don't have to put them on the ground. And they are commonly used in conjunction with general anesthesia for pain control in small animals. Also used in CRIs for pain control in small animals. You can use skin infiltration and mucous membrane applications. This is how most of us are used to doing it, doing a little line block or just a little local infiltration. By far, the most common two we're going to be using are lidocaine or bupivacaine. Lidocaine is administered at 0.0 or 0.5% to 2%. And if you need to, it can be diluted out with saline. Bupivacaine is usually administered at 0.25 or 0.5%. It has a slower onset of action, but it has a longer duration. And a lot of people will mix lidocaine and bupivacaine together 50-50, lidocaine taking effect more rapidly and bupivacaine hanging around longer. It's a good combination. We also occasionally still use bupivacaine or procaine. Those are occasionally used. Ophthalmic use, tetracaine is one of the ones that's most commonly used, and proparacaine is also used for ophthalmic local anesthesia. Characteristics of locals: number one, they are not general anesthetics. They don't affect the brain normally and have no sedative effect. And most people have had some experience in your own personal life or in your family's lives with having had a local anesthetic, and you pretty well have a good idea. They sting when they go in, they deaden the area, work good, wear off, life's good, especially for dental procedures. They have very few cardiovascular or respiratory effects, and they are excellent for high-risk patients. They exert action close to the site of injection, so they do not distributed throughout the body. They don't go everywhere. You get to keep them locally. And they don't cross the placental barrier, so they are excellent for cesarean sections and obstetric manipulations. And I freely admit that most of the time when I do my lectures, I do them very early in the morning. And if you've been through my lectures more than once, you'll find that occasionally I have problems saying the words because my mouth isn't awake yet. And ever so often you stop and there'll be a pause and I go, because I'm having a sip of a cup of coffee, and that really does help. And you may need a cup of coffee to stay awake through these. I understand. The mechanism of action of local anesthetics: they are drugs that primarily affect sensory neurons, of course, otherwise you'd feel the pain. And the drug must be placed in proximity, usually close proximity, to the neuron. It then blocks sodium channels, going back to your nervous system, and prevents generation of electrical impulses. Basically, it prevents depolarization. It stops depolarization. If the nerve can't depolarize, it can't transmit pain impulses, as if it never happened. Reversal occurs as the drug is absorbed into the local circulation. It's then taken through circulation to the liver. It's metabolized, excreted in the urine, and it's gone out of the body. These are drugs that can also affect primary motor neurons, and as a result, they will cause temporary local paresis or paralysis. The limb just won't work. Not only does it deaden or block sensory neurons, it'll also block associated motor neurons. And we have seen in conjunction with sensory neuron loss of sensation, such as when we perform an epidural block. Sometimes you will perform not sometimes. When you use local anesthetic to perform an epidural block, if that particularly is a small animal, you will not only get good analgesia, but you'll also have a loss of motor function. It's one reason that epidural opioids are such a good choice. These are drugs that affect the autonomic nervous system, and that is not always a desirable or a good thing to have happen. They can affect the sympathetic neurons between the brain and the blood vessels and internal organs. And what that is called is a sympathetic blockade. They affect the sympathetic neurons, and that causes a temporary loss of function of the sympathetic neurons. If the sympathetic neurons are blocked, it may affect the heart, and if the local anesthetic diffuses into the thoracic spinal cord, and you can end up with some heart problems. Possible, not common, possible. There is a peripheral effect where there is vasodilatation leading to local flushing and increased skin temperature. And this vasodilatation can cause, obviously, the vessels to dilate, the blood pools, and that can result in hypotension. We can use local anesthetics, obviously, topically. They can be applied directly to intact skin. And the drug molecules can, and to some degree will, penetrate the epidermis to reach the dermal layers. There is much less pain relief and shorter duration of action than if administered by infiltration. Personally, I'm not really a big fan of directly applying them to the skin, perhaps with the exception of Elma cream, but they will do a little bit of work there, and sometimes that may be desirable. There are various forms of clinical applications of these. There's ethylene chloride spray, there's eutenic mixture, splash blocks. Bupivacaine can be instilled through a chest tube to help lessen the pain of having a chest tube, possibly with fractured ribs or other things that are going on. They can be applied to mucous membranes, and there is a lidocaine spray and lidocaine patches that are available. And they can be used in various and assorted ways to help produce analgesia or deadening of skin or small areas. Routes of local anesthetic infiltration. The drug is injected into tissues in proximity to the target nerve. You better know what the nerve is because that's where you're going to be shooting. Lidocaine with or without epinephrine is most common. It can be used intradermal, subcutaneous, or intramuscularly. And it provides analgesia for surgery involving superficial tissues. Most commonly what happens is somebody comes in, small laceration, we do a local infiltration, it gets deadened while the deadening is taking place, while we'll flush it, debride it, clean it, make sure it's ready. By that time, the skin is dead. We go ahead, and that's not dead. The skin is anesthetized, and we will sew them up. We should, if we have the opportunity, do a surgical prep because we are going from skin into underlying tissues and we could carry bacteria with us. Usually we use a small gauge needle, anywhere from a 20 to a 25 depending on species. The amount of drug will vary with the species and the procedure location, obviously. The onset of action, lidocaine, takes effect in about 3 to 5 minutes, okay? And we can test the effectiveness prior to surgery. Just gently prick the skin with a 22 gauge needle. If they react, if it hurts a little bit, it's not dead yet. And if when we start doing that, they don't withdraw, it's obviously going to be anesthetized and we can proceed on with whatever we intended to do. Effectiveness of local anesthetics. Obviously, deep tissues are not affected if injection is superficial. It's pretty localized. That's why they're called local anesthetics. Anytime there's scar tissue, fibrous tissue, fat, edema, and hemorrhage, that will impede drug distribution. So if it's going into an old scar, a lot of fat, if they are edematous, it's going to cause problems with producing a good block. The duration of effect depends on the drug used and the rate of absorption by the local blood vessels. And what we can do is we can add epinephrine, and if epinephrine is added to the local anesthetic, it will then affect the rate of absorption, okay? It'll slow it down. We can use lidocaine without epinephrine, okay, if we don't want epinephrine. And your book talks about the advantages and disadvantages of using epinephrine. We can do nerve blocks, where we inject the local anesthetic in the proximity of a nerve or nerves. It will then desensitize a particular anatomic site. Greatly can decrease the amount of general anesthesia needed. Provides fairly short-term analgesia post-operatively. Shorter term for lidocaine than would be bupivacaine. If you use bupivacaine, it takes longer to take effect, but you get a longer duration of action. Nerve blocks are most commonly going to be used in large animals, but they're very commonly used in dogs and cats, for example, dentals. More and more you see people that are doing dental procedures are doing dental blocks in dogs and cats. They are very common in people. Nerve blocks are very common in human anesthesia. We can also do intercostal nerve blocks for chest surgery. You'll see limb amputations. We're not going to get into the ethics of cat declawing, but if that is something that is being done, ring blocks with cat declaws work wonders. Paravertebral blocks for abdominal or obstetric procedures in cattle. Corneal, might want to remember the name of that nerve. The corneal nerve is blocked for dehorning in cattle and as a procedure for lameness examinations in horses. Line blocks. A line block is a continuous line of local anesthetic placed between the target area and the spinal cord. The ring block is a line of anesthetic completely encircling an anatomical part. And these are used in food, animal, and equine surgery. For example, we can doing teeth surgeries or wound repairs or some other things. We can do line blocks. We can do ring blocks. Some people used to call them circle blocks. And we can do that to deaden the area. An L block is a block used for laparotomy surgery in ruminants. Laparotomy, not laparoscopic, laparotomy. And that's commonly used for cesarean sections in large animals, ruminants. Showing you some things that we can do. The top picture showing a line block, and that will then deaden the obviously the area that's blocked. But the second picture below is a L block. It's an upside down L, but it's an L block. And what that does is that will then deaden the area there in the kind of darker, what color is that? Kind of Pepto-Bismol pink color. So you can get a bigger area of deadening with an L block than you would with a line block. Line block just blocks right along the line. The L block will block an area, a square, inside the L. We can also do intra-articular administration, where local anesthetics are injected directly into a joint. There is regional anesthesia, which you'll find more in human medicine than in veterinary medicine, where local anesthetic is injected into a nerve plexus or in proximity to the spinal cord, such as a brachial procedure where we deaden the arm or the area around the arm, and affects a larger area such as an entire limb or the caudal portion of the body, for example, in the case of an epidural. Time for a sip. Paravertebral anesthesia is only used in ruminants, okay, and in that case, and really it's only used in cattle for all intents and purposes. For standing laparotomies as an alternative to an L block. In this case, local anesthetic blocks the dorsal and ventral branches of spinal nerves T13 to L2. And by doing that, it provides a wide, uniform area of anesthesia. Now, the problem with it is it can produce hind limb weakness or scoliosis. That spine just goes kind of dead, okay? Really loses any ability to provide support sometimes for the spinal cord. So you get some scoliosis. Epidurals is a regional anesthetic procedure used in small and large animals. It blocks sensation and motor control of the rear abdomen, pelvis, tail, pelvic limbs, and perineums. Epidurals are increasingly being used. They're being used in dogs, cats. They're being used in horses, cows especially. Smaller ruminants, sheep, goats. Epidurals commonly used in human beings, for a variety of procedures, most commonly associated with childbirth. And in our profession, they can be used for tail amputations, anal sac surgeries or removals, perianal surgeries, urethrostomies, obstetric manipulations, cesarean sections, and some rear limb operations. But cesareans are probably going to be by far number one. The drug of choice is going to be determined by the procedure. Local anesthesia, you can use 2% lidocaine or 0.5% bupivacaine. Post-operative pain control, you can use an opioid, morphine, Astromorph. If you're not familiar with that drug, Astromorph is a trade name for preservative-free morphine that can be used for intrathecal or epidural administration. You can use, obviously, a combination, opioid and a local anesthetic. And when you get into that, then you end up with anesthesia and analgesia. You can use an opioid and an alpha-2 agonist mixture. You can combine an opioid and an alpha-2, say xylazine or dexmedetomidine, and use those in combination, and you'll produce epidural anesthesia in horses and cattle. It will depend, again, procedure, species, practitioner's preference, circumstances, all that kind of stuff. When we're doing an epidural, the drug is deposited in the epidural space outside the dura between the spinal cord and the vertebrae. Spinal nerves pass through this space and then are affected by drugs placed there, okay, just by those proximity things. In dogs, that's between the last lumbar vertebrae, L7, and the sacrum, or S1. Here shows a picture of placement, okay? And you need to be familiar not only with the placement between L7 and S1, or the first sacral vertebrae, but also all of the terms associated with it. You need to know what the interspinous ligament is, the ligamentum flavum. I guess you probably know what skin is. The supraspinous ligament, epidural space, sacrum, cauda equina, cerebrospinal fluid, L7, spinal cord. I hope you know what spinal cord and skin are. Those are two biggies. So be sure you're solid on where you would place a epidural, particularly in dogs and to a lesser degree in cats. The local anesthetic blocks sensory and the motor neurons. Sensory block controls pain. They don't feel anything. The motor block may affect the tail and limb mobility. So their tail goes flaccid. In some cases, the rear legs go flaccid. Opioids have very minimal effect on motor neurons. They will produce excellent analgesia, but without having the effect of blocking the tail motion or rear limb motor neurons. Time for a sip. Other infiltration techniques, beer blocks. Beer blocks probably are used far more commonly in human medicine than they are in veterinary medicine. Beer blocks are an excellent technique. I'm a big fan of beer blocks. And it is an intravenous regional anesthesia. It will provide short-term local anesthesia to a limb. We can only use lidocaine. Okay, this is one time lidocaine is only used. And what you do is you have tourniquets applied to the proximal superficial vein. Lidocaine is injected into a distal superficial vein. What then happens is that area, because there's a tourniquet applied, the lidocaine infiltrates around that area. The area goes numb. It lasts for about an hour, and then you very slowly release the tourniquet, and the lidocaine then is slowly absorbed because you're releasing it slow. If you release the tourniquet too quickly, they end up with a huge bolus of lidocaine going into circulation, and that's not good. Bupivacaine, this is one time, bupivacaine is not used due to cardiotoxicity, should not be used with beer blocks, only lidocaine. This is the perfect technique. You close at 6 o'clock, and at 5:30, here comes a dog that was running around the yard and got his foot caught on a piece of sharp metal on the edging, and he's got a big laceration on his leg, maybe an inch or two, and you don't want to use general on him. So you can just give him a little analgesic, maybe a little bit of a benzodiazepine, slow him down. Go ahead, put a tourniquet on, put your lidocaine into the cephalic vein, okay, just like you were giving an injection. Hold it off so it doesn't bleed back, okay, because you've got it, the tourniquet on, and then within 3 to 5 minutes, that limb is dead. You clip, you sew, clean it up, put your bandage on, and just slowly release the tourniquet, and they're 15 minutes, they're ready to walk out the door, and there's none of that general anesthesia stuff. Beer blocks work real well. CRIs, we talked about CRIs. Lidocaine is administered to healthy anesthetized animals or animals post-surgically. Reduces the dose of general anesthesia or analgesia required, commonly used in combinations, things that I think the classic example is an opioid, lidocaine, and ketamine. Okay, and sometimes some people now are using alpha-2s, whatever, but it's commonly used in dogs, cats, and horses, probably most commonly in dogs. And of course, there's always going to be adverse effects of anything. The adverse effects of local anesthetics will include loss of motor neuron function, loss of nerve function with direct injection. In other words, if you inject it directly into the nerve, you're liable to kill the nerve. Tissue irritation, paresthesia during recovery, allergic reactions can happen, anaphylactic shock. I've never seen anaphylactic shock. I'm sure it could happen. There's systemic toxicity. There can be trauma to the spinal cord or caudate quanta if it's not properly done. There can be serious toxicity and death with infiltration into the cranial portion of the spinal cord. That's really, really, really bad. Sympathetic nerve blockade with infiltration in the cervical or thoracic spinal cord, resulting in cardiovascular and other effects. So local anesthetics are not without risk and not without consequences under occasions. The other half of this chapter is we're talking about some other special techniques, and we get into a little bit on assisted and controlled ventilation. You need to understand what positive pressure ventilation is. Assisted ventilation is where the anesthetist delivers an increased volume of air or oxygen anesthetic gases to the patient, and the patient initiates inspiration. So you're basically delivering it. Controlled ventilation is where the anesthetist delivers all the air required by the patient. There is no spontaneous effort by the patient. Okay, with assisted, the patient's initiating inspiration. With controlled ventilation, there is no effort. Okay, and the anesthetist controls respiratory rate and volume and pressure of the gas inhaled. Okay, and in most cases, we're probably going to be doing controlled. Normal ventilation, physical movement of air into and out of the lungs and upper respiratory passages. The active phase, there's inhalation. It's initiated by increased CO2, PaCO2, detected by the respiratory center in the brain. Actually, it's not so much PaCO2, it's going to be hydrogen ions because of the carbonic anhydrase system. As CO2 builds up, it is converted into hydrogen ions, and that increase in acidity as the pH starts to lower, that's when there's going to trigger inspiration in the brain. The thoracic muscles, the diaphragm and intercostals, causes the thoracic cavity to expand. Air is pulled into the breathing passages and goes to the alveoli, and then when the lungs are full, the respiratory center in the brain then detects that and stops inspiration, and we are then ready to start the process of exhalation. The passive phase is exhalation. There's no particularly active muscle movement involved in most cases, as the PaCO2 begins to rise until respiratory center starts inhalation again. So most of the time what we do is we stretch to inhale, and then as we relax, then that's a passive process. Now you can also forcefully, using thoracic muscles and other intercostal muscles, force additional air out. So there can be a active exhalation phase. If you're out jogging and you run a long way, you're going to have a very forced exhalation to try to move as much air as possible. The passive phase is normally twice as long as inspiration, and normal tidal volume will run 10 to 15 mLs per kg. Now, different people give you different figures. The number I like, and this is just me, is 14 mLs per kg. I think that is, as a general rule for small animals particularly, the most accurate figure. Okay, so if you're ever figuring the normal tidal volume on, say, a 10 kilogram animal, I would multiply it as 14 times 10 would be 140 mLs. That would be the normal tidal volume. That's my figure. I got that from Bill Muir. Ventilation in anesthetized animals differs from ventilation, obviously, in awake animals. You have a reduced amount of air entering and leaving the lungs. But everything we give depresses respiration. So animals you know, they've gotten anesthetized, everything's going to depress respiration. You're going to have lower tidal volume. You're going to have a lower respiratory rate. Tranquilizers and general anesthetic decrease responsiveness of breathing center to carbon dioxide levels, so inhalation doesn't occur as often. Therefore, less respiratory rate. And they will then relax the intercostal muscles and the diaphragm so that the chest doesn't fully expand. Tidal volume is reduced. So we're breathing slower and we're breathing in less. Potential problems with doing that? Well, there's a lot of potential problems. Number one, there's hypercarbia. It's related to the breakdown of carbon dioxide to bicarbonate ions and hydrogen ions, which can then lead to respiratory acidosis. In other words, we're building CO2. We're not bringing in as much oxygen. We can get acidotic. Hypoxemia is related to less oxygen entering the lungs to be absorbed into the blood. We're just not breathing as much. We're not getting as much oxygen. And atelectasis can be related to decreased tidal volume, so the alveoli don't fully expand on inhalation, which can then lead to partial collapse of the alveoli in some sections of the lung. They're not working, so they kind of collapse in on themselves, okay? And atelectasis is a common sequelae. This is one reason we want to give positive pressure ventilations every 5 minutes. Types of controlled ventilation, positive pressure ventilation. The patient is intubated, properly intubated, the cuff is inflated, properly inflated, and they're connected to an anesthetic machine. We can then use manual ventilation or bagging, and you bag them every 2 to 5 minutes, depending on circumstances. You may have to do more than that if the chest is open, but every 2 to 5 minutes. Some people ask, can you bag them too often? Theoretically possible, but if you stay within the 2 to 5 minute range to bag them, you're fine. I always give the lecture that, what we do is we start a 5-minute cycle of monitoring an anesthetized patient. At the start, we check physiological parameters, then we check stage and plane of anesthesia, correlate those two, write that on the charts, make sure everything's documented, bag them, and that should take right at 5 minutes, and we start the cycle all over again. There is intermittent mandatory ventilation. The patient is requires bagging throughout the anesthetic period. For example, if we open the chest, okay, lungs collapse, we have to go ahead and bag them the whole time. And mechanical ventilation is where we're using the machine. Instead of you squeezing the bag, the machine's doing it for you. Lungs are filled with oxygen by pressure of gas from a ventilator. And more practices are having and using ventilators and using them successfully. Vents, if used successfully, are very good for the patient. Manual ventilation, lungs are filled with oxygen by pressure of gas entering the airways. The anesthetist is squeezing the reservoir bag. The pop-off valve is fully or partially closed so that you can ensure that you provide positive pressure. Exhalation is passive and occurs when the positive pressure is discontinued and the pop-off valve is fully open, which allows the lungs to then empty. And what we do is in normal circumstances, we bag 1 or 2 breaths every 2 to 5 minutes as a side. 5 minutes is kind of the basic minimum. Bag is squeezed for 1.5 seconds. Okay, 1/1000. That's about it. We look at the pressure manometer, and we never exceed 20 centimeters of water in small animals or 40 centimeters of water in large animals with a closed chest animal. Open chest animals is a different story. But with closed chest animals, less than 20 centimeters of water, 40 centimeters of water for large animals, remember those figures. Periodic bagging doesn't usually provide enough ventilation. With animals with pre-existing heart or lung disease, diaphragmatic hernias, things that are really going to be a problem. Patients show shallow breaths and a respiratory rate of less than 6 breaths per minute. You can use intermittent mandatory ventilation prior to placing the animal on the ventilator to get them kind of carried over. Bagging superimposes positive pressure over the patient's spontaneous breathing efforts, which will stop in about 1 minute, okay? If you're bagging them and they're not breathing on their own, they will just stop trying in about 1 minute because you've saturated them with oxygen and taken away most of the hydrogen ions. Assisted ventilation rate, initially you go 8 to 20 breaths per minute, depending on the size of the patient. and then 6 to 12 breaths per minute after controlled respiration has been established. We wean the patient off assisted ventilation near the end of the surgical procedure, slowly allowing oxygen to decrease, carbon dioxide to increase, and as carbon dioxide and the hydrogen ions increase, they start to try to respire spontaneously on their own. Mechanical is similar to intermittent mandatory manual ventilation. Breathing is controlled by the ventilator, which replaces the reservoir bag and becomes part of the breathing circuit. The ventilator bellows automatically compress and forces oxygen and anesthetic into the patient's airway. Gases are delivered on inspiration. Pressure cycle, volume cycle, or a time cycle ventilator. Normal breathing settings for your vents. Respiratory rate you'll set between 6 and 12. Duration of inspiration you'll set between 1 and 1.5. Duration of expiration 2 to 6 seconds. And the inspiratory-expiratory ratio based on those periods will be 1 to 2 to 1 to 3. And the ventilator settings will vary with the needs of the patient, what you're doing, how big the patient is, how sick the patient is, what kind of ASA status the patient was. All kinds of things will then go into doing that. There's no hard and fast rules. You figure the stuff out, and then at the end of the day, you just kind of look at them and you think, you know, I think I'm going to do this, because you just got a gut feeling. And if you use vents very long, you'll start to pick that up pretty quick. Ventilators, there's all kinds of ventilators. This is a Hallowell. Everybody and their dog seems to make ventilators. You see a lot of ventilators coming out of used human hospitals that are used, recycled. The notes gives you all the stuff for what this is. And, you know, there's ventilators and ventilators. You'll learn to use your ventilator like you learn to use your blood machines or the radiograph. Risk of controlled ventilation, well, you can get a little carried away and you end up with ruptured alveoli. You can end up with decreased cardiac output. You can respiratory alkalosis, in other words, you're pushing too much oxygen. The ventilator can deliver more inhalant anesthetic to the patient, and there can be problems with monitoring them. They're just not as easy to monitor as manual sometimes. Finally, we need to say some words about neuromuscular blocking agents. Not much used in small animals, a little bit more in large animals. We don't really use them much in veterinary medicine as much as human medicine, because in veterinary medicine, most of the drugs we're using, both the pre-anesthetics as well as the general inhalants, are going to do a really good job of ensuring that the patient has good muscle relaxation. The larger the patient, the more you're more likely to be using neuromuscular blocking agents. And these are muscle paralyzing agents. If just given by itself, just give it by itself, the patient remains conscious and feel pain. They just can't do anything about it. They're just paralyzed. They have very limited uses in veterinary medicine. For example, animals on mechanical ventilation, so that the animal's not fighting the ventilator. Orthopedic surgery and ophthalmic surgeries, where we either need to relax muscles to get into do some big muscle bone work, or we don't particularly want the eyeballs twitching around while we're operating on them. Cesareans, they can be used to facilitate difficult intubation. In humans are commonly used along with some sort of an ultra short acting induction agent like etomidate to paralyze for emergency intubations or difficult intubations. They are often used, particularly in veterinary and human medicine, as part of a balanced anesthetic technique. These are administered when the animal is unconscious and respiration is controlled by intermittent mandatory mechanical ventilation. So either you put them on a vent or you squeeze the bag for them, because if you don't, they aren't going to be able to breathe, and that's a bad thing. There are two types. The first is the depolarizing. Okay, there's either depolarizing or non-depolarizing. Depolarizing interrupt normal impulse transmission from the motor neuron to the muscle synapse. And the one classical example of that is succinylcholine. There's a single surge of activity at the neuromuscular junction. It's followed by a period when the muscle end plate is refractory to further stimulation. It has a fast onset. They're paralyzed fast. And it has a short duration of effect. And it wears off fast, usually 10 to 15 minutes. Useful for rapid intubation. You can get them down, get them intubated. They're not going to fight you, and get them on a machine either manually or put them on a vent, respire for them, and you've got control. Remember, airway is everything. Non-depolarizing, which are really the more modern ones, interrupt normal impulse transmission from the motor neuron to the muscle synapse. And these would be things like galamine, pancuronium, atacurium, cystatacurium. There's several of these, and these are much more commonly used in human medicine. And they block receptors at the motor end plates, and there is no initial surge of activity. Okay, they work in a totally different way, but they produce much the same effect. Concurrent use with other drugs may affect their potency. They are administered by slow IV injection, effect seen usually within 2 minutes or faster, and will last 10 to 30 minutes depending on what you're using it. Repeated doses or continuous infusions can be used with some agents if they need to stay down and stay relaxed longer. It really makes assessment of anesthetic depth difficult. A lot of your twitches and your reflexes and all that kind of stuff just go away. Okay? Only voluntary skeletal muscles are affected. It does not affect the heart, so you should not have any myocardial problems. And it will not affect smooth muscle. Only voluntary skeletal muscles are affected. Fortunately, the good thing about the non-depolarizing agents is they have specific reversal agents. If you give succinylcholine, there's no reversal agent for it. You just got to let it wear off. But if you use the non-depolarizers, then there is a reversal agent, and they are reversed with an anticholinesterase agent. Edrophonium, neostigmine, proteostigmine, all these guys will reverse the effect. So if you don't like it, you make it go away. If the operation's over and you don't want to hang around for it to wear off, you can make it go away. You can maintain it light anesthesia until reversal is complete. You don't want them waking up and still being paralyzed. Make sure spontaneous breathing has started or support respiration. Pre-treat the patient with atropine or glyco to prevent adverse effects. And that's important to remember. With non-depolarizers, be sure and pre-treat with atropine or glyco, prefer glyco, to prevent adverse effects. And depolarizing agents have no effective reversal agents. There's nothing to reverse succinylcholine. You just got to let it wear off, but it wears off fast. Key points. Local anesthesia is the use of a chemical agent on sensory and motor neurons to produce a temporary loss of pain sensation and movement. Because of low patient toxicity, low cost, and minimal recovery time, local anesthesia may be preferred to general anesthesia in some patients. Disadvantages include lack of patient restraint, lack of risk of overdose in smaller patients, and technical difficulties. If sufficient quantity of local anesthetic reaches the sympathetic ganglia, sympathetic blockade may and will result. This causes flushing, increased skin temperature, and occasionally hypotension and bradycardia. Okay. As we go through and you think about local anesthesia, don't think of local anesthesia as an either general or local. Think of it smartly as and we will find that general anesthesia and the judicious use of local anesthetics in combination for appropriate procedures is the optimal way to go for our patients. Local anesthetics have many topical uses, including the application of the conjunctiva or the epithelium of the respiratory or urogenital tracts. Local anesthetics may be injected in proximity to a peripheral nerve, blocking sensation from the tissue served by the nerve. Surgical preparation of the area is necessary. It's very, very, very necessary before injection of a local anesthetic. It's got to be clean. People don't inject stuff in there and get it all abscessed. Epinephrine is commonly added to lidocaine to delay absorption of the local anesthetic from the site, but epinephrine must not be used at peripheral locations where blood supply may be compromised. Okay? You don't want to end up with necrosis. Epidural anesthesia is achieved by injecting local anesthetic into the epidural space between the dura and the vertebrae. In dogs and cats, the injection is performed between the last lumbar vertebrae and the sacrum. This technique is useful for surgical procedures in patients that are debilitated and in patients that require profound analgesia of the caudal abdomen, limbs, or pelvis. Okay, and we'll also talk about when we get to particularly bovine anesthesia about doing this. Intravenous injection of local anesthetics may be useful, beer blocks, for distal limb surgery, including amputation. And that is B-I-E-R, not B-E-E-R, blocks. Local anesthetics may be harmful if injected directly into the nerve. They may also cause temporary paresthesia, which may result in self-mutilation. Not a good thing. Adverse systemic effects of local anesthetics include sedation, hyperexcitability, respiratory depression, and sympathetic blockade. Toxicity may be avoided by limiting the amount of lidocaine administered to the patient and avoiding intravenous injection of bupivacaine. Don't give bupivacaine in beer blocks. Controlled or assisted ventilation may be used to deliver oxygen and anesthetic to the patient. Either a mechanical ventilator or manual bagging may be used. These procedures are particularly useful in patients with poor respiratory function. Never leave it up to the patient. They will always screw it up. Do it for them and you won't have problems. Controlled or assisted ventilation helps prevent the development of hypercarbia, respiratory acidosis, and pulmonary atelectasis. Intermittent mandatory manual ventilation can be achieved by gently squeezing the reservoir bag at a rate of 6 to 12 breaths per minute and a pressure of 15 to 20 centimeters of water pressure, never exceed 20 in a closed chest patient. Inspiration time should be 1 to 1.5 seconds, and expiratory time should be at least 2 to 3 seconds, usually a 1 to 2 or 1 to 3 ratio. Mechanical ventilators may be incorporated into either a rebreathing or a non-rebreathing system. Depending on the type of ventilator used, the anesthetist may control the pressure or volume of gas to be delivered, the respiratory rate, and the length of inspiration and expiration. You have control. There's no way they can mess it up if you are in control. If controlled ventilation is used, the anesthetist must use caution to avoid excessive expansion of the alveoli, continuous positive pressure, and excessive ventilation rates. Okay, be careful with these. Okay, do not overexpand the alveoli. Be careful with positive pressure. Be careful with ventilation rates. You can mess it up too. Okay, neuromuscular blocking agents may be useful in some anesthetic procedures to allow relaxation of voluntary muscles. They should never be used alone as a sole anesthetic agent because there is no anesthesia. They're just paralyzed. And if we're going to see them in veterinary medicine, probably in ophthalmic procedures are going to be number one. In small animals, urogenital reproductive procedures in large animals. Neuromuscular blocking agents may be depolarizing or non-depolarizing. Non-depolarizing agents may be reversed by the administration of neostigmine or edrophonium. They can be reversed. Neuromuscular blocking agents necessitate the use of mechanical or manual ventilation as the muscles of respiration, the diaphragm and intercostals will be paralyzed. Okay, you gotta ventilate for them. Many drugs, including isoflurane, aminoglycoside antibiotics, organophosphates, and diuretics may alter the potency of neuromuscular blocking agents. So if you're using either a depolarizing or non-depolarizing, be very careful with whatever drugs are also on board. Okay? And that's going to wrap up the presentation for this chapter. And whether you're a small animal or a large animal, and no matter what you're doing, I'll be honest with you folks, a sick baby is always a sad thing to say. Puppy, kitten, foal, calf, kid, lamb, there's just something about having a sick baby that just tugs at our hearts and just makes you want to go over there and pet them and tell them you love them. And if you can just make them well, you're going to use your magic wand and you're going to do it. So, but then that's kind of why we get into this mess to begin with, isn't it? And that's this for this chapter.